attending our HSCP Day webinar. We're delighted there's such interest in this. We have over 280 people who are registered for the day, so it's a really important opportunity for us to kind of, I suppose, recognise the important role of health and social care professionals who work across all our services in the West Northwest, and to kind of celebrate all the work that they do. So just a little bit of housekeeping. This webinar is being recorded, and we will share a link to the webinar after the event. We'll also share all the slides afterwards as well. We've got a really busy agenda, so unfortunately we haven't got time for questions and answers, but we'd really encourage you to kind of pop any questions into the chat box. We'll be keeping an eye on that, and we'll kind of respond to any kind of comments or questions you have throughout the webinar. We're delighted, I suppose, with the amount of HSCPs who kind of put in submissions to present today. Unfortunately, we were only able to kind of choose 4 of those submissions, but we had great examples of kind of, HSCPs demonstrating how they can kind of lead, learn and innovate to ensure that we're kind of providing kind of, timely, efficient services to our patients. So I'm going to hand over to Tony, who's kindly agreed to kind of open our HSCP Day webinar. Thanks, Tony.
Thanks, Catherine. Thanks indeed. It's great. Actually, I'm delighted to have been asked to open the session this afternoon, and I'm delighted to be involved as well. I have a few slides that Catherine is going to start sharing with you, but the purpose of working through this few slides is just to give a sense maybe of context of where the work that you're doing every single day fits within the context of the structures that we're implementing across the West and the Northwest, and indeed the structures that we're implementing across the country. And also maybe to look a little bit at the the vision and the mission for the HSC West and Northwest, what it is that we're trying to do and why we're trying to do it, and where do HSCPs fit within that. So that's my aim over the next few minutes. And I'm kind of working on the assumption that probably some of this stuff you already know, but for more of it, maybe not so much. So you'll all remember that the country itself is divided up into 6 regions on a geographical basis about 2 years ago, a little over that now. And within that, more recently, we've divided each region down into integrated health areas. So just focusing then on the map of Ireland on the left, it shows the HSC West and Northwest, which we've divided into 4 integrated health areas, starting north and working south. We've got Donegal, which extends down as far as Ballyshannon, but stops there. And then we've got South Donegal, which is integrated with Sligo, Leitrim, and some of West Cavan as a second IHA. Mayo sits on its own, and we've combined Galway and Roscommon. So 4 integrated health areas across our whole region. And we've put in place a management structure to oversee the delivery of care across those 4 areas. And without going through all of the names, I thought it'd be helpful even just to refamiliarize you with the people that are in those posts. Some of them have been there since for 18 months, and more of them are just very recently in post. We've only very recently appointed our regional lead for disability, and we're in the process of finalising our appointment of the regional director of nursing and midwifery. That will be complete on the 1st of May. One of the appointments, recent appointments, which has helped to finalise the clinical component of our regional management team, is the appointment of a regional lead for health and social care professionals, and that's Elaine Dobell. And we're really pleased to have Elaine back with us again. Elaine and I worked together in the hospital group some time ago for a number of years, and then Elaine left us to work on a national role, but has come back again. But it's great to have that combination. So you can see that the clinical component of that regional management team, which includes the regional clinical director, Pat Nash, regional director of nursing and midwifery, and our regional lead for health and social care professionals, also working with our regional director of public health. So it's good to have that clinical dimension to our management team, and I think it'll help to shape how we deliver care into the future. One of the key differences, I think, between our approach to the management of our services in the West and Northwest versus the rest of the country is the focus on networks of care. Now, I've no doubt that all regions will progress with networks of care over time. And in fact, I think that's certain to be the direction of travel. But the pace at which we've adopted in the West and Northwest is different. The reason for that is largely historical, of course, because we did have MCANs, managed clinical and academic networks, in the hospital group and the safety group for a number of years since 2012, and they were very important and worked very well in terms of ensuring the quality of the care that we provided, but also in setting the strategic direction. So because we had that history, we were very keen to continue it. But the history wasn't just confined to the hospital group. In fact, there are clinicians working in the management of our mental health services for far longer than we were at it on the hospital group side. And so continuing that type of approach with mental health was also very important. So the networks of care that we're progressing with straight away, you can see we've got medicine sorted and we've got surgery sorted. We're in the process and very nearly sorting out having a clinical director both for laboratory services. We have a very active cancer network of care, which has really taken on this regional role very actively. And we've very recently appointed Mandy Burke, as many of you will know, as our clinical director for mental health services. We split out women and children into women and infants, which is now headed up by John Morrison as clinical director. And we've now got a children and young people's network of care, which will be really important, I guess, in terms of how we integrate both our hospital and community services together. But I think that's one of the key differences between our region and others, the pace at which we progress with the networks of care and the commitment that exists within the region to do that. The key deliverable that we're expecting from the networks of care is that focus again on quality of care and on the strategic direction, and it's really important to us. So then, I suppose I was speaking yesterday at a meeting of the managers that are involved in the new management structure at IHA level, and we reviewed together the vision statement for the region, which was developed and adopted just about 18 months ago. Just going through it, to provide high quality, safe and accessible care to improve the health and well-being of people in the West and Northwest. So even 18 months on, there are a number of things that really stand out to me within that vision. And I think people read this in different ways themselves, which is okay too. But for me, the focus on quality and safety of care first was really important, but also accessibility. And these things are linked. Sometimes being able to access care at the right time and in the right location has a direct bearing on the outcomes and therefore the quality of care that's provided and so on. So that's really important in our region as well, where we've got access issues across our disability services and our mental health services. We've got geographical issues relating that tie in with access as well, and cultural issues that impact on access. So it's a really important aspect of the vision statement for me. But one of the things that I think is really important for us as a region as well is that we're focused not just on delivering health services and providing healthcare, but on ensuring that we improve the health and the well-being of the people that we look after. It's a tall order, and it's very difficult maybe to quantify that and to be sure that you're staying focused on it. But the fact that we have public health as part of our regional management team, it helps us to stay locked into that. Our mission supports that vision as well, again, it is focusing on access and trying to ensure that people live healthier lives. But there's what really stands out for me in terms of our mission is the commitment to the values of the HSE, care, compassion, trust and learning, and all of those really stand out very strongly. The other aspect of the mission statement that stands out strongly for me is valuing people, not just the people to whom we provide care, but the people who work within our services as well. So I suppose when I look back over our vision and mission and so on, I suppose it asks the question, well, where do health and social care professionals fit into that structure, and where can they contribute within that structure? Maybe there are two questions there. So for me, partly the question of where the health and social care professionals fit in the future. Well, first of all, absolutely as a core element of our regional management team, and as part of that, that's important to have that input at that regional level. But we're also in the process now of setting up integrated health area management teams, and I'd really like to see health and social care professionals directly involved in that as well. And also our networks of care, they're an obvious place where we haven't previously had direct involvement from health and social care professionals, but it's but again, it is somewhere where that we would really like to see health and social care professionals having a direct input into. So if that's how health and social care professionals fit in, the question is, where can they contribute? And again, it's maybe a question that I'm presenting to everybody that's listening here today, and one that I'd like you to take away and think about it, But from my point of view, when I think about health and social care professionals, I think about, the need for us to be able to cross boundaries effectively, So within our current setup, we still have that boundary between hospital and community services, and patients cross back and forth over that all the time. But I think health and social care professionals have a particular role to ensure that transition from community into hospital and successfully back out into community afterwards. I think they've got a particular role to play there, and they can contribute to our vision in that regard. But there are lots of other boundaries within our services as well. Even within community services, we've got really strong boundaries between primary care and mental health and disability services and older people services still. And part of what we're trying to do is to break down those boundaries. And again, I believe that health and social care professionals have a particular role in managing that transition, helping to break down those boundaries so that the services serve the needs of the patients and the service users that we're looking after, that they serve them better. And the third area that really strikes me is the focus on health. So many of health and social care professionals, at their heart is the focus on the well-being of the person or the patient or the service user, and the maintenance of the person's health. And that's, transmitting that then into a kind of a population level deliverable is what this region is about. And I do think that health and social care professionals will help to ensure that we stay focused on that and that we go about that in the right way. And of course, the final area is one that I think is at the top of our agenda in terms of our vision statement, which is the quality of the care that we provide. And we all know that to provide quality of care, you have to have all the right people involved. On a given day in a hospital, for example, care is delivered by teams. Effective, good quality, safe care is delivered effectively by teams. And so, that focus on quality and what health and social care professionals can bring to that, and the added dimensions that can be brought to it through health and social care professionals is really important. So look, I just want to go back maybe to where I started off and say, I was really pleased to be asked to be involved here today. I think it's arriving at a good time for us. We've recently, as I say, just appointed Elaine onto the regional management team. It's a new development for us, and it's a new management team. So it's a new approach, and it's as I say, your day to day is arriving on at that time. So I was really pleased to be asked to be involved. I really look forward over the coming years to working with health and social care professionals across all of our services and right across the region in trying to make sure that the vision that we've described there, that remains relevant, not just to the people that are using our services, but also to yourselves that are working within our services. Thanks very much indeed. Thanks, Catherine.
Many thanks, Tony, for agreeing to open our webinar today. So we're going to be hearing next from 4 health and social care professionals who've really kind of, done a lot of work kind of leading and kind of innovating kind of within their services to kind of improve access to services. So I'm just going to pop up the agenda just for anybody who hasn't seen it so far. So hopefully everybody can see the agenda there. So we're going to be having Darren Doyle kind of presenting kind of initially, followed by Olivia Burke, Nadine Lynch, and Deirdre Cleary. So Darren, I'm going to hand over to you then to present initially.
Good afternoon, everyone. My name is Darren Doyle, Community Healthcare Network Manager for the East Donegal area. Today, I'm pleased to share the learning and outcomes from our integrated GP CHN musculoskeletal physiotherapy pilot, supported through the HSC Spark Innovation Programme. I was fortunate in that I was awarded Spark Innovation funding to fund the pilot itself, which enabled us to test and implement a new way of delivering early specialist MSK assessment within GP practices. It shows how HSCP leadership, combined with strong GP collaboration, can deliver improvements in service user experience, clinical outcomes, and system flow as well. I'll briefly bring you through the problem we were addressing, the leadership role of HSCPs, what changed for service users, the outcomes achieved, and then finally our next steps. So musculoskeletal conditions are one of the most common reasons for GP attendance, and patients referred for routine primary care physio in Ireland for conditions such as osteoarthritis and spinal pain are facing considerable waiting times. And this needs to be understood in the context of overall service demand. With over 12,000 CHN physiotherapy referrals received alone in 2025 in Donegal. To give you further context, in excess of 121,000 patients were managed across HC West, Northwest CHN physiotherapy services. And that makes it the busiest physiotherapy region nationally in terms of patient contacts. So despite the high level of service delivery, demand continues to outstrip available capacity. During those waits to be seen, patients can frequently reattend their GP with ongoing pain, lack of progress, or simply seeking reassurance. So in the absence of timely access to specialist MSK assessment, GPs are often managing uncertainty. So imaging is sometimes considered to rule out serious pathology or provide reassurance, not because it's always clinically necessary, but because there was no rapid way for patients to be assessed by an MSK specialist. For some patients, prolonged waiting led to a referral to secondary care, such as orthopedics, due to a lack of improvement. So many patients in that waiting time experience deterioration, reduced activity, fear avoidance, and declining quality of life. So this project is a strong example of HSCP leadership that drives integrated community care. Alongside our 2 local GP practices and the specialist physiotherapist, I led the design of a rapid access musculoskeletal assessment model that was embedded directly within GP practices in Lifford and Letterkenny for 1 day per week in each practice. So HSCP leadership was evident in several ways, by the specialist physiotherapist providing early expert assessment, diagnosis and triage, redesigning pathways aligned with CHN and ECC principles and enabling early clinical discussion with GPs, and reducing duplication of referrals that can happen into both primary and secondary care. So to enhance integrated working with our GP colleagues, we work directly within GP practice IT infrastructure. So we use the Helix Practice Manager system for physiotherapy documentation. This meant that GPs had direct access to their patients' physiotherapy assessment and management plans, supporting real-time clinical understanding and continuity of care. Referrals into the service were managed through the HealthLink e-referral pathway, and that ensured that appropriate triage, traceability, and integration with the existing GP workflows. Alongside this, we ensured GPs were very clear on what was appropriate for referring to the service, and that the local physio departments were fully aware of how the pilot operated, how it interfaced with the existing services, and avoided confusion or unintended duplication. This slide is particularly important in terms of illustrating the service user experience and the practical impact of the pilot. The most immediate change for patients was access. So instead of waiting close to a year for a routine assessment, patients were seen within 2 weeks. Patients consistently described feeling relieved to be seen quickly, to receive that diagnosis, to leave with clear information about what was happening, what to expect, and what they could actively do themselves in terms of a self-management plan. Early intervention reduced anxiety, prevented deterioration while waiting, and it improved confidence in self-management. And that was consistently reflected in the patient satisfaction surveys, with many also reporting a strong preference to access physiotherapy directly rather than GPs as first point of contact for similar musculoskeletal problems in the future. The measured outcomes from the pilot were very strong. So from an access perspective, as mentioned, 100% of patients were either offered an appointment or seen within 2 weeks. During the pilot period, we managed 136 referrals with 129 patients discharged. Clinically, 40% were safely discharged with support self-management alone. 55% were appropriately referred on for further management within primary care physiotherapy, and only 5% required a return to the GP for that similar issue. So no patients required on referral to secondary care, as I said, to orthopedics, etc. It's worth highlighting that these outcomes were achieved over a relatively short implementation window of just 4 months, with the clinician working just 2 days per week. The pace at which access, discharge rates, and avoidance of escalation were achieved gives confidence that this model is effective and scalable when sustained. The rationale is that there is reduced reattendance, avoidance of onward referrals for imaging, reduced secondary care referrals, and earlier recovery all point toward further potential system level cost avoidance. And that's strongly reinforced by the feedback. GPs reported valuing immediate access to the MSK expertise, early clinical discussion, reduced duplication, and then more capacity to focus on non-MSK presentations. From a clinician perspective, the pilot represented meaningful early intervention work, enabling earlier assessment of life-affecting MSK conditions, timely patient education, and supported self-management. And this reinforced confidence that intervening earlier in the pathway can help to disrupt that cycle of chronicity that can develop that's also associated with long waiting times. Finally, looking ahead, there's a clear focus on sustainability, learning and scale, as you can see in the slide. From a service perspective, the priority is to secure a sustainable way of delivering this model. So that may be through recurrent funding to protect the dedicated musculoskeletal physiotherapy capacity, or alternatively through exploring how existing resources within physiotherapy services could be configured differently to recreate this role on a more permanent basis. Unfortunately, it was not possible to extend this pilot beyond the 4-month period due to recruitment challenges into the role at that time. Second, we want to strengthen evaluation and further longitudinal follow-up by capturing additional data on economic impact, outcome measures, experience measures, imaging utilization, and GP activity. There's also a need to look more closely at the patients who were referred onward to primary care physio following their initial assessment. So specifically, we want to understand how many of these patients required ongoing or repeated follow-up when contacted further down the line. And that would allow us to assess whether early assessment and education reduces future demand, including repeat referrals for the same condition, and also strengthen the preventative impact of the model over time. Third, we'll continue the GP-CHN clinical education to support evidence-based management between GPs and the physiotherapy discipline, and that's either with GP practices at a local level or within the CHN GP workshops. And finally, our ambition is to scale this model across the IHA and share learning more widely in line with Launch Care and ECC objectives. So in summary, this pilot demonstrates that earlier access to HSCP-led musculoskeletal expertise within GP practices improves patient experience, it supports the clinicians, reduces pressure on the system, and it delivers care in the right place and at the right time. Thank you very much for your time.
Thanks, Darren, for that presentation. I think it's such a great example of how kind of early access to care can kind of really kind of improve efficiency and effectiveness in the community, but also then that knock-on effect at the secondary care level when patients don't need to go on to kind of hospital for kind of, expensive investigations. So it's fantastic work and great data. So next up we have Olivia Burke. So Olivia is an optometrist working in primary care services in Galway, Roscommon and Mayo, and she's going to be speaking to work that they have done there to kind of improve access to care to their services.
Thanks, Catherine. Can you see my slides there?
Yep.
Great. Hi, everyone. So as Catherine said, my name is Olivia Burke. I'm an optometrist working in the ophthalmology department in Caspar Primary Care Centre in Mayo. Many thanks to the HSCP office today for giving me the opportunity to present to discuss the work that's being done in community ophthalmology over the past 3 years. We have introduced 4 modernised care pathways, which I'm going to outline for you now. So the modernised care pathways were developed by the Strategic Programmes Office to improve access to scheduled care and reduce waiting times. 72 pathways were identified, 36 of which were approved for funding and implementation in 2023. 3 of these pathways were in ophthalmology, namely cataract, medical retina and paediatric eye care. This was in response to the recommendations of the Primary Eye Care Services Review Group report, which was published in 2017. The pathways were to be delivered utilising community-based integrated eye care teams. So in the past year, owing to the success of the first 3 pathways, a 4th has been added for glaucoma. With significant investment in equipment and personnel, we have been able to set up multidisciplinary integrated eye care teams in 3 community sites, Mayo, Roscommon and Shantala in Galway. So slide 3 here gives us an overview of the teams now in place in the 3 community sites. So prior to the team expansion, there was only a doctor and a nurse on each site and maybe an orthoptist. So as you can see, this initiative has led to a rapid expansion of the teams on all 3 sites. So each team is led by a consultant ophthalmologist. 2 sites also have community ophthalmic physicians. All 3 sites have optometrists and orthoptists. There is a mix of ophthalmic technicians and nurses on all sites who support the efficient running of the clinics. So there are now 9.5 HSCPs in post across the 3 counties, those HSCPs being optometrists and orthoptists. So slide 3 here, this is slide 4. What has this increase in personnel allowed us to achieve? So as you can see from the graph, the total new referrals into the service has increased year on year across all sites. So from just under 2,000 in Galway, Roscommon in 2022 to 4,000 in 2025, and just over 1,000 in Mayo to just over 3,000 in 2025. This has in turn obviously led to an increase in patients seen across all sites, with Galway Roscommon increasing from just over 4,000 in 2022 to 15,000 in 2025, and Mayo increasing from just under 3,000 in 2022 to just over 10,000 in 2025. This is a mix of new referrals in from local GPs and opticians, patients released to our care from the acute hospital in Galway, and patients that we would have already been seeing in the community prior to the introduction of the pathways. So just to give you a bit of an overview of what we do in these pathways, the paediatric pathway receives referrals primarily from the Public Health Nurse School Screening Programme. The referral pathway has been refined by the orthoptists so that the referrals have a higher specificity and sensitivity, which allows us to keep on top of waiting lists. Prior to the introduction of the pathway, the doctor would have seen all of the children referred into the service. Children aged 3 and upwards are now seen by optometrists, which frees up the doctor time to see more adults and the more complex paediatric cases. There is collaboration between optometrists and orthoptists for combined clinics. This allows the patient to attend for one appointment to be seen by 2 professionals, which reduces visits to the clinic. The optometrist-led PEDS clinics are supported by either a nurse or an ophthalmic technician, which increases the efficiency and the throughput of the clinic. So at the bottom there, as you can see, this has resulted in 1,000 patients being removed from the hospital waiting lists, but it's also eliminated the long waiting lists in the community that existed before the introduction of the pathways as well. Okay, so we'll move on to the cataract pathway. So prior to the cataract pathway being introduced, all cataract patients were referred directly to the acute hospital by their GP or their own optician. They attend to the acute hospital for assessment to confirm that cataract surgery was needed. They then attended a pre-op clinic for measurements and consent for surgery. They attended again for the surgery itself, and they finally had returned 4 weeks after the surgery for a post-op review. Now we carry out all of the aforementioned appointments in the community, so the patient only attends the acute hospital once on the day of the surgery. A specific referral pro forma has been developed for new referrals from the GPs and the opticians, which has refined the referrals further. This has resulted in nearly 3,000 patients being removed from the hospital waiting lists. The pre-op and post-op clinics are staffed by a multidisciplinary team, with HSCPs an integral part of those teams. In the medical retina pathway, the doctors accept referrals directly from GPs and opticians. These patients can now be assessed in the community and only need to attend the acute hospital if advanced imaging or treatment is needed. The next step on this pathway is to set up injection clinics in the community so the patient never has to attend the acute hospital. We've also set up optom-led screening clinics for things like ocular side effects of certain medications and nevus monitoring. This has removed 742 patients from the hospital waiting lists. The most recent pathway that has been introduced, the glaucoma one, works similarly to the MedRet pathway, with possibly even less need for the patient to be seen in the hospital. Glaucoma is a chronic condition which requires yearly and sometimes biannual monitoring, so it's a lot more convenient for the patient to be seen closer to home. We have set up optom or orthoptic-led stable glaucoma clinics. This removes a large burden from the hospital, allowing them to see the patients who have more complex acute needs in the hospital. Our patients in the community now only attend the hospital if surgical intervention is required, which is the minority of glaucoma patients. And this has resulted in 650 patients being removed from the hospital waiting lists, and it was only implemented in the last 12 months. So just to close, I wanted to graphically illustrate the impact that these pathways have had on the number of new patients waiting longer than 12 months for an appointment. So with the expanded teams and the massive investment in equipment, the capacity has increased. So as of end of 2025, there are only 20 patients waiting longer than 12 months to be seen, versus just over 3,000 in 2022. Of the 20 patients, they have all been offered an appointment, so they either cancelled or didn't attend on the day. So the implementation of these pathways required buy-in at all levels of the ophthalmology chain. The consultants have shown great faith in the skills of the HSCPs, so the optoms and the orthoptists, and they've supported us to work to the top of our skill set, without which we wouldn't have been able to implement these pathways. But also the acute hospital have trusted the teams in the community to take on the care of their patients. So it goes to show that with investment in teams and utilising our HSCPs to work to the top of their skill set in a multidisciplinary team, we can make a considerable impact on waiting lists and provide the correct care to the patient in the right place and at the right time. Thanks very much for your attention.
Many thanks, Olivia, for that presentation. I think it's such a great example of how, that kind of true integrated MDT working kind of improve care pathways, and how HSCPs can kind of, safely take up roles that were previously led by our medical colleagues. So it's brilliant data there. So next up we have Nadine Lynch, who's a senior dietitian kind of working in Donegal, and she's going to be talking us through her kind of service initiatives that they have done to kind of improve access to care for our paediatric populations.
Afternoon, everybody. I'm Nadine Lynch. I'm a senior paediatric dietitian based in Donegal North, and I was part of the MDT team that was involved in the rolling out of the programme Introducing Family Foods to Your Baby. This programme is an evidence-based standardised weaning programme that was intended to be rolled out nationally. It empowers parents and caregivers by giving them the knowledge and the confidence to make informed decisions about their infant's weaning journey. So CHO 1, 3 and 5 were identified as pilot sites for this programme. In Donegal, there were 2 sites, Donegal and Cavan Monaghan. In Donegal, the programme was rolled out face-to-face and virtually, and in Cavan Monaghan, it was rolled out virtually. So Geraldine Sexton, who's Senior Project Dietitian with the Healthy Eating Active Living programme, led out on this project nationally. Fiona Murphy, Child Development Officer, Sligo and Leitrim, Kathleen Harkin, Assistant Director for Public Health Nursing, paediatric dietitians in Donegal and Cavan Monaghan, and public health nurses in Cavan Monaghan were involved in the rollout of the project. And the workshops were delivered by public health nurses and dietitians working together. And weaning is a key developmental stage, and it does have important implications for growth and long-term health outcomes. So it is important that we develop healthy habits during weaning so we can help prevent obesity and chronic disease. So Action 4 of the HSE Healthy Weight for Children Action Plan was to implement a strategic and sustained communication strategy that empowers individuals, communities and service providers to become obesity aware and equipped to change, with a particular focus on families with children in the early years. So the aim of the programme is to design and deliver a standardised, community-based weaning workshop and operating model to support evidence-based weaning practices that could be rolled out nationally. The programme was tested in a number of areas of deprivation within the Sláinte Care healthy community areas. The standardised programme ensured equity across the country, and testing it in the Sláinte Care healthy communities areas aligns with the policy priority to address health inequalities. The principles of the workshop is evidence-based and individualised to the needs of the person. It has a structured written curriculum as delivered by trained and competent educators who are quality assured. So it can be delivered virtually or face-to-face and aligns with the local population needs. So weaning can be a solitary experience for parents or caregivers. So the workshop fosters a sense of community by allowing parents and caregivers to share experience, ask questions with each other. It also supports parents and caregivers with the knowledge, the skills and the confidence to make informed decisions about the choices that they make when they're transitioning their babies onto solid foods. The workshop does adopt an equitable approach to also in that it makes sure that everybody is treated equally and there is no difference. So it is also quality assured. Evaluation of the programme was conducted. Quantitative measures were taken. The purpose of this was to assess how well the workshop met the parents' needs and its impact on their knowledge, attitude, and timing of weaning. And it was also to identify challenges that the service providers faced in delivering the workshops. So facilitators filled in a workshop evaluation form after each workshop was delivered, and participants were also invited to complete a feedback form after each workshop during the pilot programme. And you can see the participants form in the slide there. Qualitative data was also collected in the programme. So facilitators attended focus groups. Participants were also invited to attend focus groups, and there were 4 participant focus groups. The themes that were discussed for the participants were the recruitment and logistics, workshop experience, and workshop refinements. And the themes that were discussed for the facilitators were recruitment and logistics, workshop experience, barriers, and workshop content. So the key findings: 11 out of the 24 workshops that were included in the audit were delivered in CHO1, and 70% of the caregivers that attended were female. 41% of participants were referred by the public health nurse and 43% by the GP. 85% of those who attended were classified as white Irish, and 63% of babies who attended were 17 weeks or older. But you can see there from the slides that 20 out of the 137 babies that attended were over 24 weeks. There were quite a number of those babies that when they attended had already started weaning. Caregivers also reported an increased knowledge in when and how to introduce solid food safely, how to manage gagging, and how and when to introduce allergens. So the key findings: what we did know, that there was a high rate of early weaning. So the ideal window of recruitment for this programme would be 12 to 16 weeks. But what we did notice was that there were a lot of patients that were coming much older than this, and a lot of the patients had already started weaning. So the implication for this was that we needed earlier, more visible outreach and localised delivery. We needed to reach the parents before they had started weaning. The workshop was found to be, the content was found to be fit for purpose, and it was helpful, but clear, consistent messages is required because there's quite a lot of information. The participants did value the peer learning and the expert reassurance, and the facilitators found it very beneficial working collaboratively amongst disciplines. Facilitators in Donegal, however, did find it difficult to reach the vulnerable groups that we were looking to reach. So what we felt was that informal social workshops would help break down the barriers. So the implication for this is that we've now changed from online sessions to face-to-face sessions, and we're running them in familiar venues and with familiar local facilitators. We feel that this will increase comfort and attendance. So what's next for the project? As I said, the project is now running face-to-face and is being rolled out in all areas in CHAs by local PHNs and local paediatric dietitians. And the courses will be run in familiar venues such as libraries or family resource centres. Thank you very much.
Many thanks, Nadine, for that presentation. It's such an, I suppose, an excellent example of that kind of MDT approach to kind of ensuring early access to intervention, and all kind of done within existing resources as well. And so next up, we're going to be hearing from Deirdre Cleary, who is a senior psychologist kind of working with the LIN team in Galway.
Hi everyone, my name is Deirdre Cleary and I'm a senior clinical psychologist working on the Lynn team in primary care Galway City West. I am also known as Network 5, where we work with a population of around 14,000 children. So many thanks to the HSCP office for the chance to talk a little bit about the team and what we're doing here in Galway. So the Lynn team, as you'll see there, it's a Sláinte Care funded initiative that commenced in 2024 following an application from the local network manager. We work with children up to the age of 18 years and their families. And as you can see there, we have a wide range of professionals on the team. We have the only general paediatrician working in the primary care services in the country. We also have an advanced nurse practitioner. In terms of allied health, then we have psychology, SLT, OT, social work. While we don't have a dietitian on the team, the principal dietitian here is hugely collaborative and helps support clinics and case management as required. Our network manager is our project lead, and we also have admin support for the team. Crucial to the rolling out, I suppose, of our service is the placement of students and trainees who come from multiple universities across the country and are hugely supportive in the work that we do. So many of you will be aware, I suppose, traditionally primary care has been very unidisciplinary in approach. Referrers will make referrals into individual disciplines, and then children are placed separately on waiting lists, often which can be lengthy. So it means children's care can sometimes be staggered in terms they might see one discipline initially and then wait some time before they'll see the next. While there are national moves to change this through the single point of access, it can mean that children are referred to multi-professionals but not accessing care in a coordinated way. So Lynn, I suppose, was established very much with the focus on providing integrated care in primary care to complement this traditional approach, but also acknowledging, I suppose, the increasing complexity that we also see in children's services, and to offer a more holistic formulation of children's profile and needs. So in terms of what we do, children can access the team in different ways. The first being the primary care team meetings that are held monthly, where all clinicians in the network attend who are working with children, and they can bring forward children who would benefit from team discussion. Cases then that might come to Lynn are typically those that would need input from at least 2 disciplines, and that they'd also benefit from a coordinated approach to their care. So this may include issues like social complexity, high levels of distress, or the need for professionals to access another kind of lens or idea of what might be happening for their child. We also accept referrals from our paediatrician on the team, an advanced nurse practitioner. And I suppose having Lynn has supported the enhancement of interdisciplinary work across the whole network, and we really couldn't do any of the work without the support of the wider network. So it's been very much a network-wide initiative with all allied health working together. We really reach out to local networks, other children's services like CDNT and CAMS and TUSLA, in an effort to, as Tony was alluding to earlier, providing more seamless transitions between all services. We've also strong links with the Galway Traveller Movement, IPAS centres, again with the view to breaking down any barriers to service engagement. So we also carry an individual caseload for the team. So again, because we're multidisciplinary, families can access multiple professionals in one appointment. So it reduces the time spent travelling in and out to clinic. We can also share information, which really helps in terms of the wider formulation. We try to be as dynamic and responsive as we can to the needs of the wider primary care team. So we really work closely to plan and roll out groups together, support research initiatives, and we also run consultation clinics and support autism assessments that I'll talk a little bit about next. So one such initiative that Allied Health have been very centrally involved in has been a monthly multidisciplinary clinic. So I suppose it supports access to multiple clinicians in a very timely way. So any clinician in the network can refer in to us, and we typically see parents within 4 to 8 weeks of referral. So as you'll see there, we've offered 155 appointments to date, 121 have attended, and again I suppose 32 of those families have come directly to Lynn for further support. We've also then supported the wider primary care team with other cases, those other 13, and then we can also signpost families to other services that may be beneficial to them while they wait for services to start for them. So one such example, an 8-year-old girl who was referred to us by a paediatrician in the hospital. She had no involvement with services at the time, so she came to the consultation clinic, and we were able to link with parents, link with the school, see the young girl, and OT and psychology supported a referral onwards to CDNT while also supporting the paediatrician with the diagnosis of autism. So again, just reduced her time having to wait and to navigate everybody coming together to make sense of what supports would be most beneficial for her. So feedback we have received to date, I suppose, has been really positive. As seen there, I suppose a great benefit to families to meet the team in one room, access early signposting, focus on meeting families where they are. Really a focus, I suppose we try not to implement too many barriers to the MDT clinic, very much around no door is the wrong door, you know, and hoping that everybody can access us and whatever support we can provide in the interim while waiting for services. I suppose other professionals have also highlighted the benefits in that they know that they can access more timely response and onward signposting as required. Another initiative, I suppose, that we've been very centrally involved with, as of all the allied health within the network, with progressing disabilities, we've seen higher rates of referral to primary care generally around autism. And so while staff were trained, or initially, I suppose, involved in the screening, many weren't trained in formal diagnostic assessment. So with the advent of Lynn, it's spurred us on to try this and to seek external supervision and access training. So we've been able to, you know, together with working together, have completed at least 100 assessments or are underway in the network, which really reduce the reliance on outsourcing and extra costs. And we also work very closely with our paediatric colleagues. So in cases where children are known to both of us, again, we can share information and support diagnosis. So making it much more timely and efficient in terms of how we can all work together. Again, feedback to date has been really positive, and we continue to research and see how we can improve this pathway. So I suppose very much in terms of today's theme, Lead, Learn and Innovate, it's a small flavour of the work that the Lynn team and the wider primary care team are undertaking in Network 5. I suppose we hope it's illustrating how we work together has led to new initiatives, different ways of working, skill development of all allied health staff in the network, and resulting really in improved service user outcomes, which fundamentally is what we really want to be about. I suppose since the advancement of Lynn, we've also seen the introduction of new professional roles in primary care. Particularly social work, I suppose, has been hugely advantageous in a paediatric role. We've seen an increase in the number of groups and workshops rolled out, commencement of autism assessments, and upskilling of all staff across the network through increased training opportunities, and most importantly, a reduction in the length of time children have to wait to access services. We also work closely with other similar projects in Dublin and Kildare, some of which are already permanently funded, but really in an effort to establish a model of care for paediatric primary care services at a national level. And again, I suppose without the security of funding, we're always in fear of losing staff. To date, I suppose psychology has been the only consistent allied health on the team, and we've lost a lot of people due to permanent posts or promotional opportunities, so which is a huge challenge for us on an ongoing basis across the service. In terms of other key things, I suppose we're often asked if it's the additional resource or ways of working that has enabled us to effect change. And really, I suppose it's multifactorial. You know, we couldn't have progressed without the input of the whole network. And again, some of the real key issues, I suppose, with the funding that we had, we were able to upgrade the existing clinical space, making sure there's access to accommodation. We were able to have access to additional resources through ourselves. Training budget was also available, so all staff were able to upskill. And then access to supervision was really crucial as well, that we're able to access external supervision at an expert level. So going forward, I suppose we are really excited by the single point of access. We feel it'll strengthen working alliance with other services locally, enabling a clearer understanding of how each individual service operates and really supporting that fluidity of care between services. We're really eager to be part of mainstreaming this approach and working with colleagues in other networks and nationally to support the rollout of interdisciplinary working in primary care. And also, I suppose, a real crucial piece of what we do is responding to evolving needs. It's very dynamic and changing all the time in primary care, so we're really eager to continue to be as responsive and adaptive as we can. So that's us, and huge thanks for tuning in today. Thanks a million.
Many thanks, Deirdre, and it's great to learn from an example of, you know, truly kind of integrated interdisciplinary working, you know, both within your team and also kind of across services, and great to see kind of, you know, all the data as well that kind of shows the impact of your service. So next up, I'm delighted to introduce Siobhan Power, who is presenting to us from the National Spark office.
Hi everyone. Thanks so much to the West Northwest Health HSCP office for the invitation to speak today. I can see that I'm sharing my slides. I'm just having difficulty. Yeah, I can see them now. So first of all, amazing to see the turnout for such a webinar, and thanks for waiting. If you have, for my brief presentation, a little introduction to myself. My name is Siobhan Power, and I'm one of the National HSCP Innovation Fellows with the Spark programme. By profession, I'm a clinical specialist dietitian, and I worked for almost 20 years in the area of perioperative services before I joined the Spark programme. One of my roles within the Spark programme is to be a touch point and a point of access for HSCPs and indeed other professionals who are frontline, who want to learn a little bit more about innovation, who want to run something past me. So please feel free to reach out to me or to my other colleagues in the Spark office if there is something that you want to discuss with the team around the area of problem solving, challenges that you're trying to innovate through. Please feel free to reach out to me or to my colleagues. To frame my presentation, I think it's important to understand why innovation is actually so important. And innovation is certainly something of a buzzword. We hear a huge amount about innovation in our day-to-day conversations. We see it a lot on social media, but we need to understand why innovation is not a luxury, and it should not be seen as a luxury or as an add-on. Innovation is, in fact, an imperative given the healthcare challenges that the health service is facing today. We have an aging and rapidly increasing population, and in relative terms, we have diminishing resources to deal with this increasing population, and there will be a huge increase in demand for bed days and access to services in the next 20 to 25 years. It's estimated that the numbers of people over the age of 65 in Ireland will in fact double. And a very obvious and traditional solution would have been, well, we should build more hospitals, build more beds, hire more staff. But we're also facing a global shortage of healthcare workers. So the traditional approaches to doing things will no longer work. And I think the speakers who have gone before me have proved my point much better than I could, because they have demonstrated that by introducing new ways of working and by innovation, we can achieve so much more than just simply by adding on new and never-ending resources. In the Spark programme, we fully believe that innovation is not just a department and it's not just a project. We believe that innovation doesn't or shouldn't happen to a health service, it should happen through a health service. And it's by empowering and building capability of our healthcare staff, HSCPs included, that we create an environment where innovation is part of how we do our job and how we approach healthcare challenges. And at the Spark programme, we believe that it's HSCPs, such as the people on the call today, who are closest to a healthcare challenge, that has the best insights in how to address challenges and solutions and how to navigate away and innovate through these challenges. A lot of people will know the Spark programme for the various funding calls that we run, and I'm not going to go into these in detail today, because I think there is certainly an awareness out there that the Spark programme does indeed have many and varied funding calls throughout the year. Suffice to say that healthcare health and social care professionals are certainly at pace, if not they exceed the levels of applications that we see from other healthcare professionals, and we see that consistently across our different funding calls in terms of the number of applications that we get from frontline staff. So HSCPs are definitely up there, if not exceeding other professionals when it comes to applications. Last year, so 2025, we saw 31 separate HSCP-led innovation projects funded through the Spark programme. But it's not the funding calls that I want to spend time on today. I want to spend a small amount of time illustrating how in Spark we approach healthcare challenges and our methodology, and I want to signpost you to some of the resources that are available through the Spark programme to assist you in addressing healthcare challenges. And what you'll see on this slide here is a very traditional approach to problem solving. And as healthcare workers, we are very problem focused and solution driven. But what we understand at the Spark program is that when we jump to a solution, we often find that we can get to implementation quite quickly, but we come up with quite a messy implementation process. And what we urge and we try to empower healthcare workers such as yourselves to do is to spend time in a human-centered design approach and spend time with the problem. And this design approach is where we encourage people to spend more time understanding their problem with empathy, or their healthcare challenge with empathy, so that when it comes to arriving at a solution and when it comes to implementation, that the implementation is a more seamless process, because we've already anticipated and understood the healthcare challenge more holistically by spending time in the problem space. And Albert Einstein is famously attributed to saying that if he had 1 hour to solve a healthcare challenge or a challenge, that he'd spend 55 minutes on the problem and only 5 minutes on the solution. And that's something that resonates very deeply with us in Spark, because we know that time spent with the problem is really time well spent, and it leads to a much better solution. So with all that in mind, here are just some of the resources that the Spark team have to support innovation at the front line. This Spark Connect toolkit, and actually the next 3 resources that I'm going to mention, are all freely available on our webpage. So this first resource is our Spark Connect toolkit, and this is a suite of self-guided canvases that have a QR code embedded in them with video assistance, so pre-recorded videos to talk you through how to complete these innovation canvases. And the idea behind this toolkit is that teams would get together locally in their place of work to work together to better understand the healthcare challenge that they're trying to work through. And the canvases include things like mapping out a service blueprint, empathy mapping, so understanding a problem and pain points as they're experienced by all stakeholders that are experiencing the challenge. So understanding, how does the problem affect people, when, how significant is that problem? And as I said, it's very much designed as a team-based activity, either within a small team or by inviting a wider multidisciplinary team together to work through these canvases. 228 of these canvases were downloaded or requested by HSCPs in 2025, and they're proving really popular. Something else I want to mention are our free online design thinking workshops, and we run a series of about 6 to 8 of these per year. And different to our Spark Connect toolkits, this is a fully facilitated workshop that takes 1 morning, so from 9:30 in the morning to 1 p.m. They're free to attend either as a team or individually. And you'll see there that there's one coming up on the 29th of April. And the idea behind this facilitated workshop is that it is designed to talk you through a healthcare challenge using some design tools that I previously mentioned in the Spark Connect toolkit. But as I said, this is a fully facilitated offering. And Martin Ryan is our designer who facilitates these workshops. So he's vastly experienced, and I've completed this design thinking workshop more than once, and I never fail to get something new from it. So again, free to register from our website. The other resource I want to mention to you is a little bit different from the design thinking workshop and the Spark Connect toolkits that I mentioned, because they are designed to keep you in the problem space. This series of stress test videos that you see on your screen, this is designed to support you once you've come up with your solution, and it's designed to challenge you before you go and invest time in implementing your solution. So there is a series of 4 short videos, and if you watch them from start to finish, it should take no more than 15 minutes. But the idea behind them is that it asks you to think objectively about your solution before you go investing time and resources and money and effort into its implementation. So it forces or encourages people to spend time going, is this solution desirable? Like, do people actually want us to do this? Can we actually do this? So is your solution feasible? And finally, should we do this? Is this solution viable? The resources are online and it's a self-paced offering. Before I finish up, I just want to share some really exciting news with you, in that in the last number of months, the Spark team have been working very closely with the Regional Health and Social Care Professionals Office to bring what we think is a really important and unique offering to the West Northwest region. For the first time ever, we will be bringing a design thinking workshop live in person to the West Northwest region. It's the first time we've ever done anything like this in the Spark programme in the regions, and it's the first time we'll be offering such a design thinking workshop that's bespoke for health, the HSCP cohort. We expect and very much hope to be able to run this in autumn, hopefully September of 2026, and more information about this will follow. This will be a one-person, as I said, in-person facilitated design thinking workshop where we anticipate HSCPs such as yourselves will come together to this workshop, bring a healthcare challenge that you want to work through from start to finish, understand better, map out potential solutions, and leave the day with a much clearer understanding of how you want to move your solution forward. More information will be shared in the coming weeks about this through the West Northwest network. And as I said, it's something that we're really excited to be able to launch today and mention today and have on your radar as an exciting offering that's coming up. Before I finish up, I want to mention that our annual innovation conference, the Spark Summit, is going to be on the 16th of June this year. It is taking place in the Dublin Royal Convention Centre on the 16th of June. There are heavily discounted tickets available for frontline staff at just €40. So that's something else to bear in mind. And again, tickets available through our webpage. And these are ways to connect with me and the wider HSC Spark team, and we would love to hear from you, and never be afraid to reach out to me or the wider team. And thank you so much for your attention.
Many thanks, Siobhan, for your presentation, and thanks for all your support in organising that kind of workshop. And as Siobhan was saying, we will have further information coming out about that. So we're delighted to have Elaine presenting now and in post as our HSCP director. So handing over to Elaine.
Thanks very much. Thanks. Now, I'm conscious we're at time. I've got a few slides. I'm going to run through a few quick things, which are some of the highest priority things we're working on at the moment, and then just a few closing remarks. I won't go through all the detail because we'll circulate the slides and you can read it yourselves then. So, you know who we are, I think, by now, but that's who we are, just in case you're checking. Just a couple of points to say, you know, HSCPs do form up to 25% of the clinical workforce and 14% of the overall workforce, and we've got nearly 3,000 of us in the West Northwest region, which is fantastic. One of the things we're very conscious of is that supply is dropping, workforce demand is kind of lower than it needs to be. They're talking about 11 million health workers shortage by 2030 globally. So, you know, we're suffering that in Ireland as well. So there is work we need to do around this. One of the things that we are focusing on very heavily at the moment is around the practice education linked to the government agreed expansion programme, where we're looking to train another 450 odd student places over the last year and the next couple of years. A lot of these placements have already been put in place, which is fantastic. We've got a little bit more work to do to get the rest of the placements in. Department of Health has committed to us doing this, but I suppose that the key point around this is where people do placements, they then go on and take jobs. And there's a piece of work that's been done by the University of Galway recently, looking at specifically that how many of their undergraduates have had placement in certain areas take up jobs in those areas. So you can see some of the findings there, that 48% of recent graduates are now working in the West Northwest region, 64% are working in the service that they undertook a placement, and 38% in acute hospital care. So, you know, it's a good motivation to be taking students into working on that piece. The work we're doing today, we have these working groups that are up and running. We've been collecting a lot of data over recent time. And, you know, through that, we've now got 85% of our workforce kind of mapped. So 15 disciplines we've got mapped as to how many placements we're taking and how much workforce there are to support those placements. So we're working to try and complete that out over the next few weeks. We have circulated a practice education report, and that's gone quite widely now. We're talking about this at the regional management team as well for support through that way. We're highlighting the challenges that I know people face on the ground with this, around the staffing, the accommodation, the increased service demands, the time that's needed to do this, and there's a huge recognition of that. But there is the priority and the need to keep building these placements. This is some of the increases you can see that we're working on at the moment. So the blue is what we're providing in 2025-26, and the red is what we're going to need to provide by 27-28. Okay, so that's around placements. A few other bits and pieces. Advanced practice, great kind of development that's coming for HSCPs now. We're really pleased that we have a radiation therapist and a radiographer who are now advanced practitioners who are in post, or candidate advanced practitioners in post. And we have 2 physiotherapists and 1 speech and language that are coming, and it is now moving, which is great news. We've been waiting on some key information, and we've just heard today that some of that's come through. So those will be moving in the very near future. So the other piece that we went out to you before today's lecture was to get a bit of a sense from yourselves as how you want us to communicate with you, what methods you want us to use and what's priority for you. So thank you to all those responded. 149 people have responded across all different professions and all different areas. So good information. And we may well go out with another survey at some point in the future, maybe more focused on certain areas. But what we hear you're telling us is that the HSCP team, so ourselves in the regional office, can help by advocating and increasing the visibility of HSCPs. We can work on professional development and training opportunities, and we can work on service improvement and innovation. And I think today has shown us some fantastic examples of how that's been happening. What we hear from you, the priorities that you have within your services, working frontline, is the training, the CBT, mentorship and career progression, the integrated care and team working, and enhancing evidence-based practice, all really high priorities. And then we asked how you wanted us to communicate with you. So what we're hearing is email updates. So we're thinking of things like broadcast emails to just get general information out, and then targeted emails. The other piece is around HSC webinars. I'll talk about that in a second. And then obviously meetings and roadshows, which we're working on as well. So Tony mentioned in his opening piece about HSCPs being involved. It is really important. There's a great resource there that's been done by the HSCP office around effectively representing HSCPs in different fora. And we're going to be working on that. We're hoping to do a bit of a roadshow, which will bring some of this piece into it as well, to developing our skills in that. The other piece of work we've done recently is the training needs analysis. So 224 respondents, which is fantastic, across all sorts of grades there. And what we're hearing from this analysis is that the training needs particularly are around specialist and advanced skills training, which is great, leadership, career progression and supervision, and digital research and innovation skills. So we're definitely taking those things and looking at how we can seek funding, working with the National HSCP office and also working locally on that. So some of the things coming up, which is really exciting, the Spark project that Siobhan was just talking about, which is this design thinking workshop, which is great. We're working on a research series with the University of Galway for the summer, which will provide a huge amount of knowledge increase and skills around research. We're hoping to provide a whole range of webinars going forward. So we've definitely got one coming up about the library and how to access and use library services. We're linking with Coru about placement models. We've got supervision training coming up, practice educator training, postgrad CPD courses. And one of the things from today, we obviously had a lot of submissions around innovative practice and innovative solutions. So we've collated them all into a book. And we're going to circulate that book around so that you all have an opportunity to see some of the fantastic work that's going on around the region. So just in closing, thank you to everybody who's attended. It's fantastic to have you attending and your interest in what's going on across the region. Thank you so much to all the presenters. Really, really good presentations. Really good to hear those. It's a really positive time for HSCPs at the moment. I think we're really clear about what some of the things we need to work on, and we're working together really well on them, which is fantastic. We'd love to get some pictures and some summaries of what you've been doing today in the HSCP Day. We'll be putting a piece into the newsletter summarising some of it. So please do send them through to ourselves. That would be great. And I'm hoping to meet a lot of you, our whole team will, with some of the roadshows that we're going to organise, or some of the meetings that will be coming out to travel to your sites to meet you over the next few months. So it's great to see you all today. Lovely to meet you, those I haven't met. Thank you for your attention and for your involvement today. Take care. Have a good rest of the HSCP World Day. Bye-bye.